Hello everyone, thanks for joining me tonight. Now that you know a little bit more about DMD from Joy, I'll be explaining on gait pattern in the presence of DMD. There are many components that alter gait patterns, so I'll bring to light the main compensatory mechanisms and the biomechanics behind their cause. DMD will progressively alter muscle function, which leads to a necessary transition to a wheelchair as children get older. Muscle function pertaining to gait is altered beginning with those proximal to the trunk, such as muscles within the hips, pelvis, and thighs, as well as the shoulder girdle. All of these examples that I'm showing you will progress throughout the disease, and typically the loss of dorsiflexion and loss of hip extension comes before needing a wheelchair. There are several different patterns adopted in the presence of DMD to compensate for loss of muscle function. Those include toe drag and swing phase, walking on the balls or toes of the feet, hyperlordotic curve in the back, pinching back of the shoulders and tucking of the chin to help keep balance while walking, as well as pelvis drops and rises, creating a waddle while they walk. In this image, you'll see a child has adopted what's called a myopathic stance. They have a hyperlordotic curve in the back due to a weak pelvic girdle. Their knees are also hyperextended, and they'll be on their tiptoes to compensate for knee extensor weakness. We also see their belly sticks out due to weak core muscles. You can see in this video the hyperlordotic curve, as well as pushing the shoulders back and the side-to-side drop of the pelvis, as well as a little bit of foot drop. There are lots of clinical trials and clinical studies out there that analyze the effects of DMD on all types of things. However, the next two studies I'm talking about go over the kinematic and kinetic patterns seen in subjects with DMD, as well as a little bit of a connection with muscle force production. In 2009, an article comparing gait patterns in 7 to 15-year-olds with DMD to healthy subjects of the same age displayed that those with DMD had significant decreases in gait velocity and stride length during natural walking, despite walking the similar number of steps in the same time frame. When the healthy subjects walked at a slow velocity, the gait velocity was close to that seen in the DMD subjects, but their cadence was faster. As DMD progresses, the loss of muscle strength and balance leads to a waddling type walk that involves shuffling. This table displays the differences between the DMD and the healthy subjects. The red stars indicate some of the more prominent differences, including the fact that those with DMD had lower peak hip extension angles and a lower hip extension moment during stance as a result, less knee flexion upon heel strike, and when compared to healthy subjects walking naturally, there was less power generation present. This is a graph of torque by the dorsiflexors and plantar flexors throughout stance, and you'll see the dark line represents the subjects with DMD, that there is no dorsiflexion torque upon landing when they begin their stance phase. This is typically seen because of a combination of losing those dorsiflexors as well as not being able to fully extend the knee out to allow for your heel strike. This is a good picture of what I was just talking about in the last slide as to why they tend to walk on the balls of their feet. It's obviously, as I talked about earlier, typically losing the strength of the dorsiflexor, so they're not able to pull their toes up towards the rest of the body, not allowing for a normal heel strike that we'd see in a normal stride. But we also see what's called contractures, and that's, as you can see, the tight Achilles tendon doesn't let you drop your heel to the ground. In 2005, a study compared functional testing, such as running, with handheld dynamometry to see which is a better assessment for disease progression. This is actually relevant in our case because the results were such that in subjects who had large functional deficits, didn't necessarily have large deficits in their muscle force over time. This is possibly due to the fact that the human gait pattern has so many moving parts that if one system is off just a little bit, it creates larger effects down the line. This graph displays the results from the study of the functional test compared to age, and at the age of 8 years, it actually took subjects on average with DMD twice as long to complete the functional test of running 9 meters. And you'll also see that typically as you get older, the time goes down, but as age increases with DMD, the time increases to complete the test. This graph shows the summation of individual muscle forces collected in comparison with age. You can see from 5 to 8 years of age, those with DMD didn't have the typical increase in strength that comes with age. This time point also fits in with the years where the greatest decrease in performance during the functional test was noticed. I hope you enjoyed learning a little bit about the gait patterns present in children with DMD, but now it's time for me to pass it off to Lexi, who will be highlighting and recognizing research regarding muscle activation patterns.